The skull fracture we are going to talk about is a basal skull fracture, and that's because it's really different than the other ones. For the diffuse brain injury, we're going to talk about concussion and diffuse axonal injury, which is also, they abbreviated DAI. Skull fractures, guys, this is not on y'all's test. I ain't going to talk about it, but what is that? It's a bruise. Now these are the hematomas. I'm going to go ahead and tell y'all going to see the x-ray pictures, the epidural and subdural CT pictures are on your test. It ain't hard to figure out. One of them looks like a lens, the other one looks like a sickle. There you go. That's it. That ain't hard. And it'll have a scenario with it. Closed or open. Either you see brain matter or you don't. I don't know why I always thought that brain matter was like solid. It's like jelly. It really is, and it's very slippery. Either or can mean severe trauma to the brain. The pathophysiology for these diffuse injuries, for the concussion, how do we get concussions? So something hits, and usually what are we talking about here? Sports injuries. And it ain't always football. I know they talk about football, but y'all, they play soccer without nothing, or rugby. Oh, dear God. Like, them guys playing rugby, I'm like, or ladies playing rugby, they ain't got no pads, they ain't got nothing, they just gang tackling each other. Now that my son's playing goalie in hockey, and I didn't know that the bite guard helps to decrease concussion. I had no idea. And he has braces, and it has been a nightmare trying to get a mouth guard. So this is a rapid, like you're going forward and you hit a brick wall and then you stop. So if I'm going this way and the football player hits me, my brain keeps going and it hits here, but then what happens? It sloshes back and then it may actually come back and hit. What kind of injury is that called? Coup contra coup. So I get hit, goes back, and it whips forward. So I've got an injury here on my skull, then my brain goes back and has an injury here, and then it whips back, and then my brain does what? Hits here. You've got injuries on both sides of your brain, and I've got a skull fracture right here because it's a big boy that hit me. So there's a lot of injuries that go on there. It might not be that bad if it's a slight concussion, but we have found out over the years that slight concussions add up significantly. What assessment are we going to do? Guys, these assessments for these traumatic brain injuries, they are global, but they get a lot more often and a lot more specific the worse the head injury. I ain't going to say you're just going to be like, shh, you just got a concussion, go ahead. Anybody ever coached teams, especially football or one of the more violent, aggressive sports, or any of y'all's kids ever had a concussion? The coach did something, they told them something. They said, hey, what'd you say? Well, yeah, you always want to know, did you black out? And they'll tell them a sentence and say, hey, I'm going to ask you again in about 10 minutes, and I want you to repeat this back to me. If they can't, then they probably have a concussion. So, Glasgow-Coma scale, what's motor function? Yeah, what's the most simple motor function that can tell me, can you give me thumbs up? I can follow commands, and I've got enough to give this. And like you said, wiggle your toes, wiggle your fingers, especially if they're like, oh man. Yeah. Pupils. Perla. This concussions is the memory test. I don't know if there's a specific sentence that they give them. I've been around when the coaches have said it. One of my neighbors, her son got his bell rung and playing football, like the football, and guys, I don't know nothing about football, so y'all cannot laugh at me. I know you're not supposed to dive at their head, and that's where he hit him, and like, he's like my size, and the other guy picking on you, Nelson, is like his size, knocked him backwards, and I think knocked him out. Like, he was not making a whole lot of sense when he got home. He was kind of confused. But I just told him like a sentence, and I would come back 5 minutes later. Could you repeat it? A little bit, but so what am I going to tell his mother that to do over the next few hours?
Make sure you stay awake.
At least at first, don't let him go to sleep. Now, that whole thing about you got to stay awake for 24 hours, no. There is something that gets you an immediate ride to the emergency room. What kind of vomiting? Projectile. Because that means what? Increase in the cranial pressure. Something else that would get you a, bleeding.
Or like
Pupils changed.
like bruising behind the ears, isn't it?
You wouldn't see that quick. Personality changes. These are things that would set in quickly. That bruising you see probably would set in for hours.
What about like a palsy?
Any sort of deficit that is not normal for this child or adult. I always say child, but I mean, this is adults too. And heaven forbid, we've started with the blood pressure, the bradycardia. Guys, y'all have got to know what this is. There's 2 or 3 questions about Cushing's. So, being on the ambulance and transporting a concussion patient tests you're in a gangster. This is a concussion when it's that bad and they've had a car wreck and it's real bad and they get knocked out. They'll get knocked out for a minute, but they're not altered. Elena, what happened? You were in a car wreck. This and that. Okay. What happened? 11,000 times on the way to the hospital. Okay. What happened? Gave him the phone. He need to call your girlfriend. Told him, hey, I was in an accident. I just told him I was in an accident. Yeah, what? Who's the phone now? What happened? I need to call my girlfriend. There's a score for concussions, like not so bad to freaking awful. He was freaking awful. He got a ride to the trauma center because it knocked him out pretty bad, and when we got him out of the car and stood him up, he passed out. So you can get a ride to the trauma center, but they do have a brief disruption in level of consciousness. There is no comparison to this and that diffuse. When you get a DAI and that patient comes in, they're going to be unconscious. I promise you. They might be seizing. That is awful, awful. You have the shearing of the brain tissue and neurons that are ripped and dead. Like it is, in my opinion, like unless they're bleeding out in there, the worst brain injury that there is. That amnesia is, and it's like you tell them and they forget. You tell them and they forget. I don't know if that lasts for a day or two, or I've never been able to go and see them 2 days later and be like, do you remember me? Do you remember what happened? Or is there a block of time? Has anybody ever had a concussion? Do you remember before? No, you don't remember none of it. Huh. Does anybody else, y'all, is there a block of time missing? Huh.
Because like I busted my head open when I was playing tennis and like on the concrete, and I had to go to the emergency room, and all I remember is being in there, and I don't know. My mom told me I was asking like the same things, like what happened.
That is a hallmark sign. Repetitive, and you do and I probably have transported 15 or 20 at this point. Now, usually the ones that in the ambulance were bad. Now, if you bust your head wide open, you going.
Yeah, whole, like, opening.
That whole repetitive, and you try not to, but I mean, dear God. Every 3 minutes, what happened? What happened? You were running up a tree after a squirrel, and you saved it, and I mean, you could make up some stuff and make them feel good, but then it's like, what happened? The headache. And evidently, sometimes I know that whiplash can cause a concussion, and evidently that headache stays for a while. This is not projectile vomiting. This is just that nausea. Now, they might throw up. Dizziness. What are priorities with this patient? What'd you say?
Make sure they don't fall.
Word that differently.
Safety.
Safety. When NCLEX says their priority is safety, safety of environment, get away with them throw rugs. Everybody got throw rugs and little skid socks. Safety, like our safety, right? Safety from harming themselves. Him fall down, go boom.
Sometimes too.
Right. Safety from equipment malfunction. Safety from pharmacology mistakes by us. If they are dizzy, don't just send them off down the hallway. There you go. Ooh, come on all down the hallway. Blurred vision. Let's see. Blurred vision, dizzy, headache, and I got knocked out. So for the concussion, can you truly have cognitive rest? I mean, maybe when you're asleep, but quiet environment, don't go playing Rage Against the Machine with the strobe lights going. And they will keep them, if it was a sports injury, they're going to keep them out of whatever recreational sports they were in. And that's way above my pay grade when they tell them to go back. You always monitor for worsening symptoms. And it might be symptoms that they did not have originally. What tests? The gold standard for any of these traumatic brain injuries is what? CAT scan. They're not going to use dye. This is immediate. So if somebody comes in and they're paralyzed on this side, and we think they kind of call a code stroke, where are they going to go immediately? Don't matter if it's a traumatic brain injury. Don't matter if it's a stroke. Don't matter what it. Don't matter if it's a meningitis. Doesn't matter what the cause is. If they're showing stroke symptoms, no matter what the cause, they're going right to CT. And then we can find, oh my God, they're bleeding up here. Let's do this. Oh my God, they have this huge mass up here. Let's do this. This is going to be 3 days later. Why aren't these? What if their sodium's 160 and they have DI? ABGs. What other one did we not mention? Even amongst 12 and 13-year-olds. Huh? I think somebody said it. Huh? Pregnancy test. We'll go right along with that. Maybe STDs testing. How about a tox screen? There's just assuming it's a TBI, right? I know we studying TBI. You've got to do all the things to rule out different things. Don't assume it's a fentanyl overdose. And then, I think I told y'all about that. They're discharging the patient because she overdosed out, she a crackhead, overdosed out in the parking lot. I am discharging you, and you start projectile vomiting in triage because you have a massive bleed. They killed her. Yes, ma'am.
Our patient on Thursday was a suspected overdose because the niece told her, oh yeah, she uses marijuana and cocaine. She had a massive infarct in her cerebellum. And they sat her there and Narcaned her, and then they're like, oh shit, she's gonna probably die because it's where it is. But they sat there for 2 hours because they got a positive drug screen, and I was like,
You know, the thing is, so they said that she tested positive for cocaine and THC. The cocaine probably did make an infarct. So, you still got an infarct. I don't care what caused it.
yeah. I mean, I get that's the cause, but I just thought it was like how quickly they were like, oh, it's probably an overdose, you know what I mean? That's what they're stuck on, and then it turns out she had this massive
What is that called?
tunnel vision.
When you put that tunnel vision and you put those blinders on, what do I not see? Everything that's going on. Oh, you just overdosed on fentanyl. You breathing 5 times a minute. Yeah, their blood sugar's 10. And you're an idiot. You're not a good nurse. Who are you to be judge and jury of anybody? That's when you're going to miss the most important things that are going on. Because they're just a crackhead. They're just whatever. So, for them, you're going to give them Tylenol. Why am I not going to give them aspirin? Don't do that. Tylenol. Antiemetics. Zofran. We really have steered away from vinegar and wine. Promethazine. Vinegar. Wine. Especially with kids. Anybody ever taken vinegar? Knock you out? Some people, it knocks out all day long. You want some sleep? Take some. So, the generic is called promethazine. What does that sound like? Who came from psych? In here, are y'all going to psych?
No, we've already done.
Thorazine. It's in the same family. Now, it has great antiemetic properties, but it's in the same family. It's very sedating. We still give it, but it's like 3rd or 4th tier. Some people it doesn't affect at all. There are cough medicines that have vinegar in it. This is the bad one. They may not ever be conscious. Immediate coma, posturing. Pupil abnormalities, and it might, sometimes it starts out, one side is a lot bigger, the other side, but you might not see that. By the time you see it, it might just both be dilated. Severe autonomic dysfunction, what does that mean? Your sympathetic and parasympathetic have just gone stupid. It's not working. What would that look like? Neurogenic shock. It is still acceleration, deceleration, but it's 100 times worse, and the brain is actually shearing. You know how we said in the nursing home, don't just yeet the prefib up, because it actually shears and creates the injury in the tissues? This is the brain sliding against itself, and it rips the neurons. Those don't heal. That's a coup contra coup. Goes back, is hitting all around. Yes.
I just have a good question about the posturing.
Hang on just a second.
Gotcha.
There you go. Yes, sir.
So,
No, you're fine.
so the cortical is a separate posturing, right? So does that matter what part of the brain that it affects, or is that just, it doesn't?
When you see posturing, that is the onset of herniation.
Okay.
So this is for DAI, right?
Yes.
Okay.
So, DAI is the focal, not focal. The diffuse injury is everywhere. That's the reason it's so bad, because how you treat everywhere, right? All of the neurons that shearing has just ripped it apart, like you just saw, and they died. Oh wait, whatever. I guess I'm gonna play again. There's the shearing, right there.
Is that gonna be on the test?
You just need to know that it is a shearing injury and that it is the worst of the worst. If they come in a coma, you gotta do what immediately? Now, and we're gonna talk about this in the spinal. If somebody is in a bad car wreck, and they friends just come in and they try to do good, and they just throw them out in the ambulance bay, and nobody's done anything. So we want to do C-spine, right? If they're breathing 2 times a minute, am I going to worry about C-spine? No, you can't. I know how important that is. If you walk in the room and your patient has a spinal injury, and guys, I took this question out because I had so many students that missed it. But I want to talk you guys through this because this is how the NCLEX tests you guys. Remember how I told you with the increased intracranial pressure, what's the first thing you do? Elevate the head of the bed. Absolutely. Neck midline. The question was, you walk in, GCS is 4. It was 10 before. What is your first priority? Prepare for intubation, elevate the head of the bed, put neck midline, call doctor for some bullshit. Who said intubation? Absolutely. I know real world, you gonna do both. You're gonna reach out, hey, bring me the airway box. I know. I took it out because it was confusing to students. But I want to explain this so that if you saw something like that on the NCLEX, I know what we do in the hospital because we do those things collectively, right? Y'all got a brain, you get in your nurse brain, you yell, bring me the airway box, bring me a doctor, bring me somebody that can incubate this patient because their GCS is damn near dead. And you are going to elevate, yes, I know that. That's what I told you to do. If you see it on the test, if you don't intubate them, it ain't going to matter how much you elevate the head and get that neck just pretty straight. C-spine don't matter. They're going to die. Airway patency. Airway, C-spine. It never trumps that. The only thing that ever trumps airway is catastrophic bleeding or if disability puts you in airway. There ain't nothing that trumps airway unless you're going to bleed to death before you can even get to airway. That's it. You can't stop all that other stuff. But it's like I said, I know we're going to do it all together. And you probably got somebody standing outside the door you're going to scream at, right? I get that. We are talking about a test. When you get to NCLEX, I need you to remember that. I know what we, and our experience and the things we know were gonna happen kill us on that test. I need you to think test the day of the test. After that, when you pass, I'm gonna yell at you if you don't do all those things, right? Why didn't you yell out for the airway box, right? But I took that question out, but I just want you to realize that. Whoever's phone that is exactly the same case as mine. I was like, what's my phone doing? So, GCS lesson 8, intubate. I want to keep their oxygen levels within normal levels. PaCO2, what's normal level? 35, 45. Head of the bed, 30 degrees. Neck, midline, no hyperflexion, no coughing, no suctioning. Now, if you need it to suction, you will, but don't go in there and flip it to 150 and just stick the thing down in there and walk out. No excessive stimulation. What other safety measures are we going to take? Seizure precautions. You're going to pad the sides of the bed. If they start seizing from the primary injury, what's going to set in? Secondary injury. You're going to increase oxygen demand. Oh, and then they're going to get a temperature because you got all this metabolism that's going in up here. Oh, now you're going to make the secondary injury even worse. I need to think 10,000 miles down the road, they're going to be given prophylactically what kinds of medications? Seizure meds. If they posturing when they come in, they gonna get this because they've got edema. Their ICP is going up. Sedatives, seizure meds, antipyretics. What's that? Fever. What controls your temperature? Hypothalamus. If your brain is swelling, what happens to the hypothalamus? It gets pressed on, right? So what might it do?
Freak out.
It might freak out. Your temperature might go up to
107.
106, 107. What happens to your metabolism?
Accelerate.
What happens to your secondary injury?
Gets worse.
It does. Sooner or later, you go into herniation, neurogenic shock, dead. If you're not thinking 5 miles down the road, you're not going to think about these things. Are you going to write these orders? Nope. But you're going to anticipate these orders. And if they're not being given, hey, Nelson, hey, are you going to write me the orders for the Kepra? This is the standard for up here, and you're new. I know that. But we take such good care of our patients, and I know you're the new resident, so you want to do like everybody else, right? Right. The other one for diffuse, the injury is everywhere. This is focal, which means what? Right there. Basal skull fracture, where's the injury?
Basically.
Now, what's the problem with that? What might happen? Somebody said it. No, that's not what I'm looking for this time. Your CSF leaks out where? And your nose. Now, does it look like snot? Nope. It might have a tinge of yellowish to it, but usually it is absolutely clear. How do you know it's not snot? It's snot. Snot. You can test for glucose.
Isn't it sweet?
You can test for glucose. How can you find out?
Well, it's going out your ears. Exactly.
You don't know. It can be coming out.
Oh, can you put a tissue in blood? It will go quicker than blood because it's there.
What is it called? Halo test.
Oh,
Halo
what?
sign.
Is that right?
What color sheets are on their bed? White. Usually. if you see blood dripping out of their ear, even if you don't think it's there, go over there and look. And guys, it happens just like they say. I'm not 100% sure why it does that. It separates out the blood, and they call it concentric rings, and it halos. And the first time you see it, you're like, oh my God, oh my, that's not a good sign. What is the biggest risk with this? You got a hole at the base of your skull. Infection. Everything that's out here can get up here. Sometimes it's not that much of a fracture. Now, if everything out here can get up here, what am I not going to stick up their nose? No, because there's all those, and these are true images of an NG tube in here. Nothing gets stuck up their nose or in their mouth. If they say that, you be like, you can call the MP or the PA that can do this, what guided? Ultrasound, or you can send them down to interventional radiology. My name's Bennett and I ain't in it. I'm not sticking nothing in any orifice up here. I ain't sticking nothing in there. Well, I don't know what we're sticking. Nope, negative. I've only seen the images. I've never been anywhere, thank goodness, where somebody actually did that. Yeah, the NG tube was like way back here. That probably didn't help them out very much. Now, Nelson, you're talking about this. What is that? Battle signs. There's where? Right back here. It's this. Bilateral peri-orbital ecchymosis. You look like you got the little raccoon mask on. What is hemotympanum? All that together tells you what? They have a basal skull fracture. Guys, infection is the biggest risk with this. It can be a little break, it can be a bad break. Now, if it is a bad break, can you herniate down through that? Yes, you can.
Is that the halo test?
Yes, you see that? It is a different color. That's blood. Halo test. And I mean, if you didn't do that, you just think they're bleeding out their ears, right? But anytime you have a head injury and anytime somebody's bleeding out their ears, that ain't normal. I don't care if it's closed, open, as of otherwise undetermined. If you have any sort of trauma from anywhere up here and they're bleeding out of their ears, you need to investigate that. What is that? Raccoon eyes. That's battle signs. Right there. You can do, the halo test takes that long. Whoever said about the glucose test, yes, you can see if there's glucose in it. You're always going to do vital signs monitoring. You're always going to look for Cushing's triad. These people are not necessarily just going to be unresponsive when they get there. Ask them what? Guys, you got to do a pain assessment on these people. It probably hurts. What are our priorities with this? What do we need to monitor closely? Huh? What do we say is a big risk? Infection. What am I going to look at? CBC. right? What assessments? I want to look see if they get a fever, right? Start showing signs of inflammation. Here again. Now, will a plain film x-ray show skull fractures? It will. We're not going to waste time, but if they can get this, like, on the way down, but this is what I want. That is important for you guys to know. That's the gold standard. I did not do good with the animation here. Neuro exam, GCS. The first thing is, hey, what's your name? What's today? AA and O times whatever. Look to see if anything's coming out their ears, their nose. Full set of vital signs. Glasgow Coma Scale. Do you just do that once? No, I need to do trends so that I know if it was 10, then it's 9, now it's 5. Pain meds, anticonvulsants. A lot of times if you had a traumatic brain injury, they're going to give you those meds prophylactically. CT scans, they're going to, if you are leaking cerebrospinal fluid, they're going to do an analysis on it. And antibiotics. If there is a basal skull fracture, I've always just seen them, once again, prophylactically give them antibiotics. Because there's a really good chance you're going to get an infection. Where is your basal skull? Does anybody know? It's like right here. So if it's leaking out, how hard is it for bacteria to get up in there? Not hard at all. They probably will be getting very strong, broad spectrum. I promise yes sir.
Why is the use of antibiotics prophylactically debated? It says that in the slides.
Do what now?
Why is it debated to give antibiotics prophylactic? It says their use is debated. So is it just like just in case it's you don't want to create like something resistant? Okay.
The use of antibiotics is like for anything else. Are you prescribing it when we don't need it? And you're going to create some super infection like MRSA or VRE, which we don't want to do, but I don't want them to die either. So it's kind of that fine line. Guys, I am not trying to confuse y'all by changing these slides, but it never fails. I find something that's more concise with the same information after the fact. These are the hematomas. These are the only 3 that you are responsible for. And I will download this to replace the other one. Epidural, subdural, and subarachnoid. We already said that the epidural,
Sit arachnoid, that made me think spiders.
that's why, because it looks like a, y'all want me to put this on there now?
I already have that one.
Yeah,
you're on
you're on
it.
it.
Yeah.
Girl. See, I'm 5 steps ahead of myself. That's why they call it that, because it looks like a spider web. And what kind of bleed is an epidural?
Arterial.
It's an arterial. This is a neurological emergency. Dot, period. This don't take long to kilt your patient. These are just common presentations for all of them. They don't all have this. They might have an altered LOC. A lot of times they have a headache, nausea, vomiting. Some of the worst ones though, what kind of vomiting? Projectile, pupil changes, motor deficits, Cushing's, which is a very late sign, and it usually means the onset of brain herniation. Epidural. This is an arterial bleed. You have a rapid accumulation of blood. That goes back to the Monroe-Kelly. Does it have any space in there for that to go? It does not. If blood is going in and going past the 10%, something's got to go out. And usually that means the brain goes out, that little hole. This is a neurosurgical emergency. This is the hallmark sign for epidural hematoma. It comes in 3 phases. There is a lucid interval. You might miss this if they're brought to the ER. What does that mean? The injury or the bleed starts, and they get knocked out. Let's say they're in a car wreck, and you get there and they are unconscious, and they come to and they're like, Jesus, and they're making sense, and all of a sudden they go out. They ain't coming back to, unless you can get them through all this, and it ain't gonna be right now. There is no set. They're going to be alert for 5 minutes. There's no defined time. But they go unconscious. They come back for that temporary lucid time period, and then they go unconscious again. Rapid neurological decline as that bleed expands. What do you think the only way you can solve that problem?
Surgery, draining the blood out.
Pretty much. You got to either relieve the pressure. Sometimes, if it's not that bad, they can take them to interventional radiology and try to put a coil in there to kind of cauterize it. Those are very specialized. They'd have to be downtown for that kind of stuff. Trauma, skull fracture. A lot of times this is the culprit. Middle meningeal artery. Guys, this is an arterial bleed. You remember when we talked about arterial bleeds? It's catastrophic, blood on the ceiling, blood on it sprays everywhere every time your heart beats. Lucid interval followed by rapid deterioration. It is a lens-shaped hematoma. It's here somewhere. There you go. It looks like a lens of your eye. Here we go. Those are the ventricles. What's happening? It's being pushed. Here we go. If it is clotting, I need to take out the clot. What's osmotic diuretics? 3%, maybe even mannitol. Seizure prevention. Monitor for ICP. Maintain the airway. If that patient comes in and you suspect an epidural hematoma, you need to be calling what department pretty quick? Neuro and surgery. Neuro will call surgery. But it's kind of like when a patient comes in and you think, ooh, they might be having a heart attack. You're going to call the cath lab, but you're going to start all the things. You're going to get them naked. You're going to shave all down here. You see what I'm saying? Like, it's everything in that bundle. There's nothing wrong with, oh, Lord, I think they have an epidural bleed. We're going to get them ready to go to surgery. Does this patient need to be here? What specialty does the city of Clarksville and Tanoga not have? No. Closest appropriate hospital. That patient needs a what? Helicopter. If you can't get a helicopter, you need a prescription for diesel fuel and 100 miles an hour going down the interstate. We cannot take care of that patient. Period. They're either gonna die on the way or they're gonna die in that emergency room. That is the honest truth. They need a neurosurgeon, a neuro ICU. We can't help that patient. We can't even stabilize that patient. As that bleed expands, what's gonna happen? They're gonna get yeeted to Jesus. So you can either die being transported, and as the one that's being the paramedic before, that is not a nice feeling. That's the only chance they have. So you can either sit over there and let them die, or try to get them to Nashville, right? Closest hospital is not always the closest appropriate hospital. Now, subdural hematoma comes in two flavors. Acute, it's not cute, it's acute. Less than 48 hours, chronic, more than 14 days. What population does this happen to? Why? What happens to your brain tissue as you get older? It atrophies. So you got more space in there for what? Your brain to bounce around. So, and the bad part is, if you at the nursing home and Miss Jones fell down, and she said, "Ooh, my hip hurt," and 15 days later, she has this, she can't walk, she's lethargic, she's confused, and they take her to the emergency room. What do they not remember? That she fell. And what do they say is going on? She just got dementia. She got the Alzheimer's disease. And she has what? She is slowly dying. But I mean, if they don't know that she fell or don't remember, you have to have a high index of suspicion here. Did you have a question?
Is the chronic, or is that specifically for the elderly, or is that as a whole, like the subdural hematoma?
It's just a subdural, it's just a chronic. It just,
For the elderly.
that's just a population that usually gets it. Somebody whose brain has atrophy, it gives it more space to go around. The acute, severe headache, decreased level of consciousness, seizure. So it sounds a lot like the epidural. The epidural might happen over minutes. It is arterial. This is venous. It is between the dura mater and the arachnoid. High impact trauma. Now, this might be a fall from the same level, right? Rapid LOC decline, focal deficit. Does that look like a lens? That looks like a crescent moon. Guys, I'm not going to give you one that you kind of can be like, I ain't going to give you this one. I ain't going to make it that easy. And you will have a scenario. Does everybody know what I'm talking about when I say crescent moon? Y'all stick with me here. And I ain't gonna ask you, this is a hypodense crescent on CT. This is still emergent. This one might still require a burr hole. Don't get your blinders on. Don't tunnel vision. They just old. I heard a little old lady, she was about 92. And this doctor, young resident, comes in and he's yelling at her. She said, "Honey, I'm old, I ain't deaf." All right. You don't need to know the CT image of this. Subarachnoid hematoma. So you understand by now what I mean when I say hallmark signs. This is the worst headache of your life. It came on, and I don't know where they get these words from, it came on like a thunderclap. And it ain't like, I don't know other words that you could use for that. It's always the worst headache of my life. It came on like a thunderclap. What is this? Sensitive to light. And I am ashamed to say, there's been 3 of my most not proud moments where I did that tunnel vision. We actually had to, I had been awake for 27 hours, and I was mad because there was 4 cars out in the driveway, and this lady had migraines, and she wanted to take her to the hospital, and I'm totally judging her, right? Being judge and jury, because I was grumpy. We had to break the door down, because she wouldn't come answer the door, and she said, oh my God, the light hurt my eyes so bad. I'm sitting there going, woman, you got a migraine? You can't drive. Then she said, oh my God, this is the worst headache of my life, and I am so grumpy. I never heard her. I took her to the wrong hospital. We flew her out about 5 minutes later after I got there. Tell me how great she did not die, I think, because I was calling that hospital. I had a friend that worked up there because I felt awful. She didn't have a bad outcome, but could it have been awful? The other one was, I don't remember how many weeks pregnant. I'm like, you ain't even but 9 weeks pregnant. And like, almost climbed in the back of my ambulance. Oh my God, my stomach hurts so bad. And my left shoulder hurts real bad. See? I had been awake for 24, guys, this ain't no excuse. I had been awake for 24 hours. I'm grouchy. Oh my God, my shoulder. And I'm like, is you 9 weeks pregnant? You can't even, what did she have? An ectopic pregnancy. That is a hallmark sign, K-E-H-R. She ruptured 5 minutes when I walked through the door, and they're running down to the OR. Thank God they had OB surgery and saved her life. She would have bled to death. I didn't even run lights and sirens with her. If I would have been listening to her the second she said that, I should have been driving 250 miles an hour down the road. Thank God it didn't. These are the lessons you learn. She could have died. If I would have been further out, would it have been my fault? Absolutely. Because I was judge and jury, right? Why am I telling you these stories? I want you to learn from mine. You're going to make mistakes, but I also want you to learn from mine. This is what it looks like. It looks like a starfish. Where is that bleeding?
In the brain.
On the brain.
It's kind of laying on the brain, and it's kind of down in there. What is nuchal rigidity?
No, when they can't move their head.
They won't move their neck. What does that sound like? Don't get tunnel vision. So if I can't move my neck, and they got a fever. Oh my God, I've got the worst headache of my life. It came on like a thunderclap. And they ain't a college dorm student. They live out by themselves in the woods. They don't have any of the other things why they should have meningitis. I'm going to take them to CT first. I ain't going to do the LP first, right? You wouldn't do that anyway. These are our priorities. You are going to do frequent neuro checks. You are going to keep head midline. Don't let them go to the bathroom and strain. Don't suction them. No coughing. Head of bed 30 degrees. Not 45, not 90, not 60. Meds. 3% saline. Mannitol. I'm not going to give you a specific anticonvulsant, but a lot of times it is Keppra. Does anybody know the other one?
Dilantin.
It might be Dilantin, but a lot of times it's phenobarbital. They will give Dilantin too. Why sedatives? Huh? Why would I want to keep you relaxed? To prevent straining. If I get anxious, what happens to my heart rate? What happens to my metabolism? What happens to that secondary injury? It starts happening and it gets worse. So, remember we talked about sometimes they might actually put these people into an induced coma. This just shows you the different places that bleeds might be. You have to treat the cause. And it all goes back to the Monroe-Kelly. If you've got too much cerebrospinal fluid, you're not going to treat a bleed. You put in a drain to get out the cerebrospinal fluid. If it's the brain is swelling, I'm going to give you diuretics to reduce the edema, right? If it's too much blood, remove the clot. Treat seizures, keep them normothermic, patient position. If it's too much cerebrospinal fluid, go in and do surgery and put in a shunt. Did you have another question?
Yeah, I'm at 3% and that, is that just supposed to be
Normal saline. I'm sorry.
3%?
Yeah,
Is it a hypertonic though? We still say
same thing.
Same
So we
thing?
still say, okay.
Do you know why that is?
No, that's fine.
Okay.
So is that the same thing that as the one before? With
Yep.
this- Okay, so it's just written a different way.
So,
Still 3%. Okay.
this is normal saline, 0.9. Hypertonic.
So it's still no over at 3%.
ISO.
Okay.
ISO perfect. I'm gonna stay right where I'm supposed to be. Hypertonic. What am I going to do? I'm gonna pull. I got all the stuff, all the salt, waterfall of salt. I want to pull that to decrease the edema. Mannitol is the same thing. This pulls more. They say there's a 10% saline. I've never seen it. That would, like this medicine on Lifelike, the writing is in red. We would keep it in 3 biohazard bags. Like you had to sit there and be really irritated by the time you got to it. Because why? I don't want to give it by accident. You will kill your patient. So, 3% normal saline is the same thing as hypertonic. I'm sorry I didn't say that a minute ago. You need to normalize their electrolytes, right? I don't want their sodium to go up. Craniotomy. Take out a part of the skull. They actually will keep that. Why? They might can put it back in place. I would rather put their parts back in place. Craniectomy. Guys, if it's really bad, crushed, they can't save it. This is a burr hole to relieve the pressure. Like I said, it just looks like a Black & Decker. But it's like I told you the other day, sometimes that doesn't work. When they go to relieve the pressure, the brain swells out, and that's game over. Alright, y'all get up for just a second, take a quick break.